people joining us from across the country. So it's my huge pleasure to introduce our speakers today. Kieran Walsh is Clinical Director at BMJ. Brendan Lee is Area Manager from the HSE South. Dr. Conor Malone is the National Healthcare Wikipedian in Residence. And Dr. David Hanlon is a GP and the National Clinic Advisor for Primary Care. So initially we're going to hear from Brendan, who will set the context. Brendan is going to hand over to Kieran, who will take us through the wonders of BMJ best practice. And then we'll have a discussion together with Conor and David at the end and incorporate all of your questions and suggestions. So it's my great pleasure now to hand over to Brendan. Over to you.
Thanks very much, Maureen. And just in setting the context, I thought I'd take a recent example and one we've all been immersed in the last nearly 2 years now, the COVID-19 pandemic. And we initiated a COVID-19 evidence service in response to huge demand for information around the new disease. We initiated that in March 2020, and that is still ongoing. We provide literature searches and, perhaps more importantly, evidence summaries on questions relating to COVID-19 from frontline health workers and health managers, and that's coordinated through the national clinical programs. From our point of view in producing those evidence summaries, there are two things we want to ensure: the quality and comprehensiveness of the evidence that we're putting into the summaries, that is, we're getting the best available evidence, but also the speed of response. I think everyone would agree over the last 2 years that what happened during COVID-19 was that time itself seemed to evaporate for everyone, and that evidence was needed in a condensed, synthesized format. The next slide, please, Naomi. Part of the great value of a product like BMJ Best Practice is the fact that the evidence is synthesized, mediated by clinical experts, and synthesized into a format that gets the evidence to people faster and better quality information. Part of our reason for buying BMJ Best Practice was to get better quality information into circulation, not only within the health service, but also in the general population. And we were delighted to be able to purchase BMJ Best Practice for all Irish citizens, not just the health sector. Thanks, Naomi. I think the WHO put the dilemma best in a statement from September in 2020. They said, we're not only fighting a pandemic, but also an infodemic. That COVID-19 was the first pandemic in which technology and social media were marshaled on a global scale to keep people informed, productive, and connected. However, as we all know, there was also widespread circulation of disinformation or misinformation. And that misinformation costs lives. It threatens diagnostic testing or vaccination campaigns, polarized debate, amplifies hate speech, and allowed the virus to thrive. And the WHO at the time called for the timely dissemination of accurate information. Thanks, Naomi. And against disinformation or misinformation, the onus was to get the best evidence, to combine it with clinical expertise and patient values and preferences. In our way, in the service we initiated, we played our part. We've produced 220 questions to date. They range from sort of 20 pages to 700 plus pages in length. The quality improvement element is in synthesizing and providing timely access to that evidence. It'll be quite easy to provide huge volumes of evidence, but it's sifting through that, getting the best evidence and getting it to people in a timely way. That's the value of evidence summaries and of a product like BMJ Best Practice. And why do they matter? Well, they protect patients and health workers, they help model and predict the course of the virus, and assist in the configuration and design of health services to fight COVID-19. Just 3 very quick examples over the next 3 pages of questions we've been working on recently with NIAC, the National Immunisation Advisory Committee, who are charged with the vaccination rollout. and the vaccination rollout, of course, was subject of a lot of disinformation globally. And we've moved from very general questions like this one, 199, what is the efficacy in preventing transmission? Next slide, please, Naomi. Two more detailed and complex questions which is involving comorbidities, like question 205 here. Are those with heart failure at greater risk of severe infection? And the final slide then, Naomi. This is one that's going through our evidence summary process at the minute. Question 215, does immunity wane faster in certain subpopulations? And by using products like BMJ best practice, we can make recommendation based on the best evidence for people, for example, dialysis patients, solid organ transplant recipients, and the immunocompromised. And that informs decisions around the prioritization of vaccinations for those subpopulations. That's just in a very general way setting the context, and I'll hand over to Kieran now from BMJ Best Practice.
Thank you very much. Thank you very much, Brendan, and thanks very much for having me today. I'm just going to share my screen now, and you should all be able to see my screen. And right, so thanks again for the invite. Kieran Walsh is my name. I'm Clinical Director at BMJ. I'm a geriatrician turned editor turned educator. It's great to talk to you today, and I'm going to talk to clinical decision support and quality improvement, the challenge of looking after patients with comorbidities. And specifically, I'm going to talk to these things. First, a brief introduction or reintroduction to BMJ best practice, then to the challenge of comorbidities. Going to talk briefly about the comorbidities tool, the new tool we built, run through a clinical scenario, and discuss its implications for quality improvement. And if we have time, we'll do a demo at the end. So, BMJ Best Practice is our point-of-care clinical decision support tool. It's there for all members of the interprofessional team. It's created as an interprofessional resource, so we're delighted that it's available in Ireland as an interprofessional resource, structured around the clinical consultation, and it's evidence-based, continually updated, and practical. We're delighted and glad to say, thanks to the HSE, that it's available to everybody in the Republic of Ireland. Essentially, it's a knowledge resource. The idea is that it will answer your clinical questions, but you don't just get any answer. You get an answer that's focused on what's important to you, which is, and what's important to our users is interesting and not something we would have predicted before we spoke to them over the past few years. First of all, it's speed. They want an answer within seconds. They want actionable, practical information that they can put into practice at the point of care. They want access on a mobile, online, offline via an app, ultimately integrated into electronic healthcare records. And they also want to be assured that the content is continually evidence-based, it is continually updated, and also evidence-based. And yet there are problems with evidence-based medicine. Here's a list of such problems by a paper from Trish Greenhall et al., published in the BMJ a few years ago. I won't read them all out. Range from information overload through to lack of shared decision-making, through to evidence-based guidelines, often mapping poorly to complex comorbidities. And we think that this last one is an important one. And the reason why guidelines are inflexible, rules mechanical, prompts technology driven, is because of comorbidities. And it leads to the refrain that evidence-based medicine doesn't work in the real world. And so we think if we tackle the problem of comorbidities, it could knock out lots of different problems. And so this led us to look hard at the problem with comorbidities a couple of years ago. Comorbidities, obviously, when patients have more than one illness. And comorbidities are important, but not much neglected. Here's a quote from Chris Whitty, England's chief medical officer, the Tony Holohan's equivalent in England. training from medical school onwards, clinical teams and clinical guidelines all tend to be organised along single disease or single organ lines. And so we looked at detail initially at comorbidities in the acute setting. Most patients in the acute setting have more than one medical condition, but clinical guidelines only focus on single conditions, which is an important statement. When comorbidities aren't taken into account, patients get suboptimal care, worse clinical outcomes, longer lengths of stay, increased costs. Yet there's more. 1 in 4 adults in the Western world suffer from more than one condition. In the UK, 1 in 3 adults admitted to hospital as an emergency remarkably have 5 or more conditions. And people with multimorbidity have poorer functional status, quality of life, higher uses of care, and also have higher mortality, which all places a real burden on healthcare systems. And yet, clinical guidelines only focus on single conditions. And so we started to look into this, and we did some research amongst junior doctors who worry that comorbidities might be neglected, overlooked, and they find managing patients with multiple illnesses complex. Senior doctors are worried about junior doctors, and hospitals or healthcare providers are worried about senior doctors, junior doctors, but also quality of care and cost. And underneath cost is length of stay and readmissions. And so we thought we have to do something here. And so we recently launched BMJ Best Practice Comorbidities around a year ago. The idea is that you add the patient's comorbidities to an existing management plan and you get a tailored plan. And thus you learn how to provide holistic care. So the idea is you have a patient with an acute condition, maybe pneumonia, and you can add 1 or more of these chronic non-communicable disease comorbidities to the management plan. And what we found is that you get an exponential number of potential combinations. And combinations are common and single diseases increasingly rare. A cardiologist told me recently he couldn't remember the last time he saw a patient with a single disease. To date, it's the only decision support tool that does this. So how does it work in practice? Well, we've put together a clinical scenario to bring it to life and to show how it works in the real world and also to look at it from the patient experience point of view. And so here it is. Imagine we have an 82-year-old man with cough and shortness of breath, past history of chronic bronchitis and type 2 diabetes, and comes into the emergency department with crackles and wheezes. And so you don't have to be a geriatrician to work out that this man has an acute exacerbation of COPD and type 2 diabetes. It's not a diagnostic challenge, and yet it is a therapeutic one. So let's look and see why. So imagine for a second that the scenario splits in two. And in the scenario on the right, we treat the COPD, but also the diabetes. What happens? You'll give the patient bronchodilators, oxygen, antibiotics, steroids, but with careful monitoring in light of the comorbidities, careful monitoring of the diabetes, a review of the diabetes medication, monitoring of the blood glucose, and a check on the patient's feet. And that's exactly what the comorbidity tool tells you and enables you to do. And what happens? Well, when you do all these things, then you will carefully manage the diabetes in light of the steroids. You will ensure that the blood glucose is closely monitored. You'll check the patient's feet. If you don't, then the patient will develop hyperglycemia, renal impairment, potentially a pressure ulcer. And what happens within a couple of days? One patient, you're starting to plan to send them home. The other patient, you're starting to plan to send them to the high dependency unit with uncontrolled diabetes, renal impairment, and a pressure ulcer, a scenario that plays out all too commonly. And so one patient goes home, and the other patient, it is possible to rescue patients like this, but so much the better if it weren't to happen in the first place. And so I know I've zipped through these slides in the interests of time, but to slow down for a second and think about what's happened there from the patient's perspective, We've seen pain, inconvenience, discomfort, and distress. From the hospital's perspective, poor quality of care and increased costs related to the number of bed days and the type of bed days and follow-up and treatment of the pressure ulcer. How common is this problem? Diabetes is a comorbid condition in 10 to 20% of patients with COPD. In Ireland, 380,000 people living with COPD. So it's a very common problem, but that's just one combination. We spoke, and Brendan actually mentioned COVID-19, heart failure, and depression. 25% of patients with severe COVID-19 have a history of heart failure. COVID-19, previous coronavirus outbreaks have been associated with depression in survivors, same as the current outbreak. And we know there's been many patients with COVID-19 in the Republic of Ireland and throughout the world. And I mentioned depression deliberately because mental health comorbidities can be particularly neglected. Comorbidities in Ireland. I've given this talk in various countries around the world, mainly via Zoom in the past 18 months. Comorbidities are a problem everywhere. You can see the first study by Morrissey et al. Of patients with cardiovascular disease, 77% had multimorbidity. The second one, 20% of patients with type 2 diabetes in Irish general practice were taking an antidepressant or benzodiazepine. And the last analysis by Hernandez et al. Showed that multimorbidity is now the norm rather than the exception in patients over the age of 50. What about comorbidities and quality of care? Well, what I've shown you is a knowledge resource that will help to improve quality of care for patients with comorbidities. But a knowledge resource isn't completely enough on its own. We also need to think about how we communicate with patients, how we provide care as a team, as an interprofessional team, how we help them prioritize their illnesses, how we find out what matters to you, what matters to the patient when they have multiple illnesses and multiple problems, and try and address the problems that are most important to them. And it needs both. Healthcare professionals need the knowledge resource, but also they need these skills. And of course, comorbidities are a challenge to guidelines and guidelines producers, because most of the guidelines are about single conditions. They're also a challenge to quality improvement, because all too often measurement is about single conditions, intervention is about single conditions, and ongoing measurement can be about single conditions also. So how do we enable quality improvement when we have scenarios like this playing out, where a junior doctor told me how we used the tool and sent in this short summary, a patient with ischemic heart disease and upper GI bleeding, or acute coronary syndrome and upper GI bleeding. And it shows the complexity of clinical care, and our patients with multiple morbidities just won't fit into a simple box. And so we did a brief evaluation in the UK where we asked junior doctors to use the tool and let us know how they got on, and fill out a short qualitative questionnaire telling us how they used the tool, not what they thought of the tool, but how they used the tool. And here's the types of things that they said, and I won't read these all out, but once again, they show the importance of team-based care. They show the importance of managing patients in the context of complexity. And this is the difference that it made to their patients. Patient involvement is also really important at BMJ, so I just wanted to put a slide in this regard. So we co-created BMJ best practice with patients. We regularly co-present with patients, and we get their feedback on the resource, and we try and ensure that the resource tackles problems that are important to them. Now, I think we probably have just about enough time to do a very brief demo of the of the resource, a brief live demo. I'm just going to stop sharing for a second, and I'm going to see if I can now share my screen. And this is BMJ best practice for those of you who haven't seen it before. And we're going to tackle Brendan's problem, a patient with coronavirus. We're going to go to the COVID-19 topic, and it shows how to manage and diagnose patients with COVID-19. Go to the treatment algorithm, and you're asked, does your patient have any comorbidities? And we'll say our patient has heart failure, as I and Brendan mentioned, but also depression. So we'll click on those, and we'll show the treatment algorithm. And we'll just scroll down, and we'll assume our patient has severe COVID-19. And as you can see, it gives standard advice for the management of patients with COVID-19, hospital admission, oxygen therapy, etc. But also you can see that these C icons are appearing. So we'll click on that, and it says steroids, and it says, your patient has depression. Be careful in patients with COVID-19, when you give steroids, can make the depression worse. We'll just go down to another one, and antipyretics analgesics. And we'll click on that, and it says heart failure, warning, you need to be patient. You need to be careful with non-steroidals in patients with heart failure and COVID-19. So two simple, straightforward examples, and yet they're simple, straightforward examples that that all too often go wrong or neglected or overlooked in the acute setting or in the chronic setting. I'm going to stop sharing now, and I won't go back to my slides. But suffice to say, what we're trying to do in BMJ best practice and BMJ best practice comorbidities is provide a resource that will improve quality of care, like everybody else is trying to do. What makes us different? Well, in this resource, we feel we have a clinical tool designed to help real-life patients with multiple real-life illnesses. And it's trying to do a difficult thing, which is to get healthcare professionals to stop and think, and indeed make a strategic step in evidence-based medicine, clinical decision support, and quality improvement, moving from academe to the coalface, from fragmentation to holistic and high quality of care, and from single diseases to comorbidities. Thank you very much for listening. I hope that's been helpful, and delighted to try to answer any questions that you might have.
Kieran, thank you so much for the whirlwind through and revealing some of the really special features of BMJ best practice comorbidities. It's really refreshing to see its equity of access and its use by expert patients, and the fact that it's downloadable and usable on many devices, including offline on the app. So thank you so much for sharing that with us. I would like to welcome now the members of our panel, Conor Malone, Dr. Conor Malone and Dr. David Hanlon. I'm going to start by asking Conor if you have any initial observations on the use of BMJ best practice to share with our participants and Kieran today. Thanks, Conor.
Thanks very much for including me in this, and thanks Brendan and Kieran for really good overviews. And so my background is ophthalmic surgery, and when we see patients who have other conditions, it can be really difficult to go outside of our area of expertise. But I found it very useful, not just for that, but also for tracking what I've been looking at. CPD or CEUs are becoming more and more important for medicine, nursing, other health and social care professionals. So one thing that I only learned about recently was the fact that as I use the app, it tracks what I've been looking at. And I know that some colleagues of mine use it for their portfolios for training, but I have used it to be able to go back and look again and see where the gaps are. So I think that's something that's useful for people to know, that it's kind of a record of your learning.
Thank you, Connor. Great practical tip. So you're getting multiple uses of the app and the device simultaneously. So fabulous time saving. Thank you. And David, Dr. Hanlon, can I ask if you've any initial experiences from using it in primary care and community settings that you'd like to share with us?
In general practices, was the one of the great values of this thing is it's there, it's available all the time, and you know we're mostly consulting. We're there with a PC in front of us. We've access to the internet, but you know you often want to find where's the information or what can I check, because there's such a variety of things. And as Kieran says, you know, comorbidity is totally the norm in general practice. We're definitely like the cardiologist. No one has, you know, very few people have just one disease when you get down to it. So having access to a tool like that, I mean, I actually have BMJ Best Practice as my kind of second home screen. So every time I open the browser, it's just there, and to dip in and dip out of it. You know, and again, the range of things we deal with, you know, you're going to come across things all the time that actually aren't that common, you know, or at least they aren't common presenting to us. Example recently, you know, very prosaic in lots of ways, but someone with really acute urinary colic is pain at ease, and the question, you know, so like it's a classic condition, it's a classic presentation. He was a perfect textbook presentation of it, but at the same time, it's not a condition I manage regularly. In fact, you get very few people who turn up in general practice with that classic textbook acute presentation with the franchimaturia and the pain and and all that. And I was going to go, well, so I'm thinking, okay, his pain is eased. Do I need to send him to the hospital? What's the standard of care here? And you know, what is it? You know, if the acute episode is easing, what do we need to? So I mean, I was able to open up BMJ Best Practice. Looks like standard of care is CT urogram within 24 hours. I said, okay, he needs to go to ED because there's no other way of getting that done. And so that helped me make a decision very quickly, a reasonable, logical decision. Like say to him, look, I know your pain is settled, but this is the standard of care. This is what you need to happen, and this is what I need to facilitate. So it kind of keeps me safe and keeps the patient safe. As Karen said, very much when we were looking at acquiring BMJ Best Practice, I mean, the things that really stood out for me were those things like, you know, actionable decisions, digestible amounts of information. You know, you need something that you can get to a point. My looking, I think, scenario here, I've got a paramedic heading out on a call. He'll be there in 3 minutes. The blue lights are on. He knows something about the patient, but he never heard of this condition before. How in that 3 minutes can he find the information he needs to have and be able to apply that when he arrives on scene? And that was the kind of use case I was thinking about. That, you know, we need to meet those kind of needs. Or the NCHD on call middle of the night. What am I dealing with here? You know, being able to access the information in a digestible, actionable way, reliably, mobile, offline. Those are really kind of really important features, I think.
Great, lovely. David, thank you. And I'm curious, you've all mentioned the interdisciplinary use. Anybody got any reflections on how the different professions can come together to use BMJ and how it helps?
I can make a start on that, Maureen. Thank you. So yeah, the resource is certainly in the UK increasingly used by doctors, both junior and senior. I think everybody is kind of, even specialists have certain generalist needs, and we can help provide them resources that will meet their needs. Generalists, of course, they certainly do. We have a growing number of nurses and nurse specialists who are using the tool, also physician associates, as they're called in the UK, and also pharmacists in particular, we've discovered have been high users of the tool, which of course we're delighted about. In the UK, certainly many of these allied healthcare professionals and nurses and pharmacists have taken on new roles and increasingly are taking on bigger roles, and they actively want a resource that doctors are using as well. And so we've been really, really happy to provide it to them as well as the doctors.
Thank you very much, Kieran. That's great. And can I ask, Conor, you mentioned earlier in how BMJ best practice might be integrated within our electronic health records in development. That's one I'm really curious about. Some of your thoughts on that.
Yeah, it's one of the really important things about electronic records. They're not just about storing information. It's about giving you access to up-to-date information. And BMJ best practice as a point of care tool is really useful when you can connect it to an EPR. Like many of the maternity hospitals, St. James's Hospital, for example, all have EPRs, and you can directly link out so that if a patient is coded as having, for example, acute asthma, you can integrate it so that you click on the diagnosis and it brings you to the relevant entry in BMJ best practice. And it's very rich. So, it's not just about a page with a load of instructions or guidelines. There are images, there are videos, there are references, and there are calculators, risk calculators, which are really useful. So if I am working on an acute ward, whether you're a nurse, doctor, whatever reason you're coming to see the patient, having access from the EPR out into this really rich textured view of the patient's multiple conditions is so helpful. And then you can get an evidence-based, you can look at which are the European guidelines, which are the UK guidelines, and it's a really broad view that you can then take into account, even if it's at 2 a.m. when you may not have a senior colleague available to you.
Thanks, Conor. So there's very exciting times ahead for us as we develop our electronic patient records across Ireland. So good to know that that possibility is there to build in. Thank you for that. Kieran, I see a practical question in the chat box that you might be able to help us with from Shauna. Thank you. Is there a way to save or bookmark a page or topic overview apart from downloading the PDF?
Yes, you certainly can download the PDF or access via a mobile or an app. But we have bookmarking functionality. I'm not 100% sure we have that currently, but I can come back. I'll check and I'll come back. I also wanted to say that access is really important, be it via EHR integration into the electronic healthcare record, or also via an offline app. We've done a lot of work in the app so that it's quick to download, so that it'll work on any device, so that it uses minimal space on the device, and importantly, that that you can access it offline. I'll come back via bookmarks, possibly after the event. But one other important thing that I wanted to say is that we're really interested in getting feedback. So if people wanted to email or get in touch, have other suggestions, new functionality, new resources we should add to the tool, please do let us know. People think BMJ is kind of an ivory tower type organization where we go to the library every day and read journals. We don't. We actually talk to both junior and senior clinicians, doctors, nurses, pharmacists, other healthcare professionals all the time to find out what they need. And that's what has brought us to the place where we can provide them with resources on a mobile that they'll be able to access by a paramedic within 3 minutes, as David is saying. Thank you.
Great, thanks, Kieran. And you mentioned the app. I'm really interested in if any of our panelists have experience of using the app that they'd like to share.
Certainly, I download the app and have it because you're working out of hours or whatever. You just need to have it there. I think the other thing that's worth mentioning is, because of the way HSE has funded and acquired this, that it is actually it's very accessible, and it's very accessible to everyone. So anyone in Ireland can access this and download it and get and use it. And there's an important bit of patient empowerment in that. There's an important bit of equity and allowing people to care for themselves and feel confident that actually their management is appropriate. And I think I think patients are, certainly I don't feel under any difficulty kind of looking up and see what the guidance is and be able to say, look, I've checked it, here it is, this is what the guidance says. I think some people used to feel a bit insecure, like, well, if you didn't know it, kind of, well, you weren't cutting it here really. But I think because the patients will look it up for you anyway. If you can point people to a reliable source, then they're less likely to be off on some bizarre chat room or finding something rare, or all the evidence for ivermectin, or pick your other choices. So I think that's for a lot of patients who will be able to get into that. It's well written resource. It's practical, as Kieran says, and it's accessible in lots of ways. And I've no worries about pointing a patient to it and say, well, look, there may be a few big words here, but you might still find it very useful.
Thanks, David. And just specifically to come into the patient information leaflets, like there's resources for healthcare professionals. In parallel to that, there is resources for patient information for patients, and it's created specifically for patients. A huge amount of work to kind of make the resource, make the complicated medical content accessible for patients. We aim for a reading age of between 12 and 14, which is really, really difficult to do. But that's what we have to do if we're going to meet the criteria of the information standard. And of course, people talk about evidence-based medicine like it's an academic thing, but actually evidence-based medicine should be about, I think as Brendan said, should be about the research base, but also the clinical expertise and also the patient's needs and preferences.
Thanks, Kieran. That's great. I see some lovely comments. Chat box, very complimentary about the resource and the access. And notice, Brendan, you might like to come in. Ciara Kirk, our colleague and pharmacist, as you talked about, Kieran, talking about access through our library services. Anything you'd like to add there, Brendan?
I only just got back in. I got thrown off the call, but absolutely, go to the website hselibrary.ie. It's an easy one to remember. You can set up your access. There's BMJ best practice and a host of other evidence and knowledge resources there for people to connect in with.
Great, lovely. Thanks, Kieran. We're coming towards the end of our discussion, but one provocative question maybe to ask, very topical in our world in Ireland, is sláinte care. So maybe each of the panelists might share with us your one on how BMJ best practice comorbidities may help us in meeting our ambitions for sláinte care. Who'd like to start?
Well, I think the point I made earlier there about patients having access to it and empowering the patient and so on, it certainly fits well with sláinte care. I think also the reality of trying to deliver more care outside of a specialized acute hospital setting means that we need to have confidence that actually the people who are delivering that care will have access to the information and the resources to do that safely, and that there's a kind of that there's some kind of agreement about that. So I think both of those things fit very well with with the deployment of BMJ best practices we've done.
Thanks, David.
I agree with David. It's very important that everyone has access to the same information, whether it's the patient should have the most access to everything, but also, if GPs are speaking to specialists in hospitals, they should all be singing off the same hymn sheet. And as more complex care moves out into the community, I think it's very important for primary care providers to have as much information to what they can expect they can deliver, and then when they do need to refer a patient for tertiary level care, that they know what the pathway will be, and then it's much easier for everyone in every discipline to understand together what the patient will need and what we can offer them, because otherwise it's impossible to coordinate. But exactly as David said, patients having access is really powerful, because then they come into their appointment or for their treatment, you know, being fully engaged and being able to take control.
Great, lovely. Thanks, Conor. And Brendan, a quick question for you in the chat box. Is the HSE library available to Section 38 organisations?
There are separate libraries. Our intention would be for the library ultimately to be similar to the way BMJ best practice is set up, open access with no barriers. So we're working through getting rid of some of the historical barriers that include Section 38.
Great. Good news, Brendan. That's great. Thank you very much. Another question. Any tips from Bernadette? Thanks, Bernadette, for introducing BMJ best practice to clinicians who may be technophobic, perhaps even hostile, if that could happen, to point of care tools. So any practical tips for appealing to the hearts?
Yeah, well, I would say that to have a go, to register and log in, it's relatively easy to use, both on a laptop or a mobile or a desktop or whatever you're comfortable with. We in creating the resource, we get junior doctors in, GPs, senior hospital doctors in to use the tool, and we watch them as they use the tool. And so it's built with user experience in mind. The tool is also consistent. So once you've used the resource to look up COVID-19, then you'll be much faster the second time when you're looking up type 2 diabetes or whatever. So I would say, even if you feel you're a technophobe, it's easier than you think, I think.
Great.
I think it depends. I mean, obviously, okay, there's that very small number of Luddites over there who still have a Nokia and maybe just a landline. But you know, anyone who's kind of using a smartphone at all, this is extremely accessible. And the fact that it's there in your hand, you know, that problem and that benefit of your smartphone is it's there all the time, and it's instantly accessible. And so you're not, if you're in a hospital, you're not going off trying to get access to the PC, or is the Wi-Fi working, if there even is such thing? Have you got a signal? It's there. I mean, back in the day when I was a junior doctor, we were going around with a BNF in one pocket and an Oxford Handbook of Clinical Medicine, a useless thing, but everyone had to have one in your pocket. I mean, what junior doctors have now, or what all of us have now, in terms of being able to access the phone in our pocket, who would want to be pulling out their book and leafing through that? Come on.
And
So
once you actually, I was just going to add that
Conor, go ahead. Go ahead. Yes.
Once you start using the app, you realize how easy it is, and it is so much easier than having to find a book and rifle through it. So just the ease of use is key, and giving feedback is actually really easy. So you know, you'll see throughout the app there's a kind of a smiley face and a sad face, so you can immediately say, you know, if you think there's an error, if there's an issue, so you feel like you have some influence over it. Whereas if you have a book or a printed guideline, you cannot do that. You know, you're stuck with it. So it feels very dynamic, and it really feels like you are looking at the latest information, and you're doing your best then to share that with patients, rather than wondering, oh, is this, you know, a couple of editions ago, do I need to update it? So it's reassuring, I think, particularly if it's something that you don't come across very often. But also, I know people had mentioned earlier bookmarks, but there's a history tab, so that's what I use. So if I know there's something that I see fairly regularly, but it's still complicated, I can go back into the history and just scroll down or search it. So that's my workflow when I use it. And then you miss it then if you don't have your phone. So it very quickly becomes a part of your work life. So I'd say if you can get someone to try it for a day, you'll convert them fairly quickly.
We put them in touch with Colin Devine, who's online with us. Colin, thanks, who's given us the comment, Finstic app, previously unaware of its existence. Really useful tool, the Armoury. So thanks for sharing that reflection, Colin. So sadly, I think our time together is drawing to a close. What I would really like to sum up by saying how fabulous it is to hear about the holistic approach, combining that really accessible best practice with what matters to the person. So thank you. On your behalf, I'd like to particularly thank Kieran, Brendan, Connor, and David for sharing with us their wisdom, insights, and tips today. To thank Stephanie and Naomi from the technical team who've kept us all glued together. Thank you for that. And just as we finish, I'd like to share with you 2 invitations to Talk Timers out there to help keep us connected. The first is an invitation to invite you to opt in to join our QPS network map. It's a tool to see people with an interest in quality and patient safety across Ireland. It's available on our website. The link is just dropping into the chat box now, and there's a quick survey that allows you join the map. And the map is searchable. You can filter it. There's a geo and a main map. You just see a still of the main map on the right. You can filter members by role, organization, interests. You can view individual profiles, and you can connect with and collaborate with others via the map. So look forward to seeing many new faces on the map. There's a short survey for filling in, and be sure and fill in your connections at the end of the map. A second offering is, if we go back a slide, Naomi, thank you, is QI Talk Timers also might be interested in applying to become a member of the Q community, which is a membership organization of people leading improvement across the 5 countries of the UK and Ireland. It's available to anybody in Ireland. There is an application process who's leading air quality improvement. Caroline Lenny-Nannon, my colleague who's online with us, is coordinating Q membership across Ireland, and her email address is on the slide. She'd be delighted to talk to anybody interested in applying to become a Q member. So, upcoming webinars. Our next QPS webinar will take place on they all take place on Tuesdays between 1 and 2. We're taking a short break for midterm and the Halloween bank holiday, but our next webinar is on Tuesday, the 2nd of November. So date for your diary. Evelyn Casey is the program lead for the Deteriorating Patient Improvement Programme, and herself and colleagues will be sharing insights on QI and large-scale change at the webinar. So we're very much looking forward to that. So a date for your diary. So a window as we close out will pop up before we log out with a few short questions. We really appreciate your feedback, and that will help us to improve our series. So thanks in advance for sharing with us. The recording and slides will be made available on our website very shortly. So tell your colleagues all about QPS Talk Time, and most importantly, tell all your colleagues about BMJ best practice. We look forward to hearing how you're using it. Thank you, everybody, for joining us this afternoon, and goodbye.